This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadurzadeh.
And I'm Dr. Brian Schmutzler. We are sponsored by Butterfly Network. When it comes to successful ultrasound guided procedures, precision is everything. That's why IQ3, Butterfly's handheld POCUS device, contains advanced features to support procedural success. With Butterfly's needle in plane, out of plane, I'm sorry, preset, you can visualize the needle tip within 1 millimeter after insertion. I will say I used this specific preset yesterday because I had a tough block I was doing. I think Heather was actually here recording, so very cool feature.
Nice.
Butterfly's biplane imaging, the only multiplane imaging in a handheld ultrasound, lets you see both short and long axis views simultaneously in real time. And Needle Viz enhances your ability to track the needle in plane from entry point to the region of interest. Butterfly IQ3 also delivers image quality similar to a cart-based POCUS system at 1/10 the price. And unlike a cart, you can carry it in your pocket to conveniently use where you want, when you want. So whether you're inserting IVs, which I'll have a video about soon, performing regional anesthesia, conducting gastric assessments, cardiac assessments, lung ultrasounds, or anything in between, Butterfly IQ3 is the perfect probe for your practice. Visit store.butterflynetwork.com to claim a soft case with the purchase of an IQ3. Use code Brian25 at checkout. Terms apply. So everyone will notice we're not in the same place this week. Vahid,
Which
why
is
is
a
that?
first for us. This is a
I
first for
know.
us.
I know. Why is that?
Well, I texted you today and I'm like, I don't think we should be in the same place, buddy. I've got,
Yeah.
remember our first episode? Go back and watch that one. We
Yeah, there
talked
we
about
go.
the new strains of influenza and neurovirus and all that stuff. And
The
I've got one of
quademic.
those. Yeah,
Hmm.
is that what they're calling it these days?
Hmm. The quademic. Yep.
Quad.
RSV, RSV, influenza, coronavirus, and norovirus.
Can you have all at the same time? Because I think I might have all at the same time. Um,
I hope not.
well, I'm on the up and up here, hopefully. So we'll see.
Yeah.
But yes, I said, Brian, in you're the best interest of you. Let us do this remotely. But
Remote. Yep.
instead of talking about the quademic, which is very interesting, by the way, I have never heard of it referred to as that. But we're going to talk about United Healthcare. I know you've got some hot button issues that
Hmm.
you wanted to hit on last week. We were in Boca Raton last week, but
Yeah.
this week we're back and we kind of want to touch on United Healthcare topics.
Yeah, so and I think anybody who's listened to the show realizes that I'm not a huge fan of insurance companies in general, and especially United Healthcare. But I think really what's been trending on social media, and I have no way to independently verify this except what's been on social media and what she's shown. But that Dr. Elizabeth Potter, who I believe operates in Texas, she and you guys may all know this story already, and we'll link it below, but. She basically had a patient that she was operating on, doing a breast reconstruction surgery after breast cancer, and got a call apparently in the operating room from the insurance company United Healthcare, supposedly one of her peers, and I'll explain the process of prior authorization and denials and all that kind of stuff as we go along. Who asked her to step out and speak to the person on United Healthcare's line to verify that that patient actually needed to stay overnight after their procedure. Now,
During the procedure.
during the procedure, yeah, and now what I believe, and this is what at least what she's posted online, she was doing what's called the deep procedure, which is essentially where you take one part of the body, and I'm not a surgeon, so you take one part of the body and do a flap where you pull it up to reconstruct the breast. Yeah, I used to do these a lot when I was a resident, and those patients would stay 2, 3, 4 days. So, this is pretty clearly an inpatient procedure. It's a big procedure. You're doing both breasts at the same time, reconstruction with a flap. It's a big deal. And so of course it was our good friend United Healthcare who decided they needed to ask for prior authorization while she was operating. Now she's done a bunch of stuff online, made a bunch of videos, all that sort of stuff. What's interesting, and again, we'll go through a whole process in a minute. What's interesting is since that time, she's apparently received at least one, maybe more letters from the legal team at United Healthcare threatening her, basically telling her to stop talking about it. And so I thought that was interesting as well. That not only they're doubling down now, right? They're not just saying, "Hey, we need you to scrub out of surgery to talk about admitting your patient." Now, because you upset us, we are, going to send you a threatening legal letter to try to gag you and not talk about the issues here. So, thought that
Well,
was
this
that
is
was pretty interesting.
well, it's just interesting to me because not the same exact situation happened to us, but I mean a similar situation where my wife is in the hospital for the first 2 days of the 31 days she was there before she gave birth. And what happens? The United Healthcare calls the attending who is at Memorial Hospital and says, "We're not going to pay for the first 2 days." And she's like, "You are? And why are you saying you're not?" "Well, we don't believe that her life was in danger, the baby's life was in danger." So I don't understand. I mean, again, now this to say that we're very thankful that insurance did cover the whole 31 days. Um, but I don't understand why they're doing this in the middle of A, procedures, B, hospital visits. Why are they interfering at such weird times?
So the process is that when you do anything that's not emergent, right? So if you walk into the ER and you got a broken leg, you just get treated, right? There's no
Right.
there's no issue with that. The problem is non-emergent things, right? So admission to a hospital for a non-emergent issue or a non-emergent procedure, meaning that you could probably do it later if you needed to, right? And so what the insurance companies, especially United Healthcare, but what the insurance companies want are prior authorizations. So they want a whole set of documents filled out, sent to them so that they can then approve that you should have the surgery, that you should be admitted to the hospital, that you should stay in the hospital. And so my guess in your situation, I don't remember the specifics of that. It's been a little while, but I think in your situation, she was having some issues with the pregnancy, went to the ER, got admitted, and then after she got admitted, they decided after a day or two that she was just going to stay for the rest of her pregnancy.
Correct.
And so my guess is what the insurance company did is they called your OB and said, "Well, you didn't ask for a prior authorization till day two, so we're not paying for day one and day two." That's probably what they did. And it's the same playbook that we've talked about with these insurance companies from the beginning is they do everything they can to not pay for care. This is the problem with insurance companies in general. They make money when they don't pay for your care. So it's in their best interest to say, "Oh yeah, we're not paying for those 2 days because you didn't get a prior authorization," even though clearly it's all part of the same admission. And obviously in this situation, it's clearly part of the need to have this surgery. The patient has breast cancer. She has to have a mastectomy, so removal of both breasts, a reconstruction, and they chose a deep procedure. And and then she's got to stay in the hospital because she had this procedure. But it sounds like they're trying to blame this Dr. Potter for not not submitting the proper paperwork, not waiting for the prior authorization, whatever the case may be. But it's still asinine that a clearly inpatient procedure for a clearly at least urgent medical need wouldn't be covered. And just like in your situation, clearly the admission was needed. Why wouldn't you pay for the first 2 days? Oh, because the doctor didn't call the second you walked in the hospital and said, "This person might need to stay."
That's crazy
You
to me.
gotta authorize it because they don't know at that point, right? When you walk in the ER, you didn't know that your wife was going to stay for 31 days. You thought maybe it was just overnight, like the three times before. So there would be no reason to get a prior auth at that point. And the insurance companies use these little loopholes to just not have to pay for your care.
What? Now, what if she didn't take that call? What if she waited till after the procedure to take the call?
So I don't know 100%. So we don't know all the specifics of the story, but potentially, if she wouldn't have taken the call and would have finished the procedure and admitted the patient directly from the PACU and then called the insurance company, potentially the insurance company could have denied the inpatient stay, which means that the of course, we're going to keep the patient in the hospital, right? So it's going to end up on the patient. The patient's going to have to pay for it. Just like had your
Just
OB not
like,
called the
right.
insurance company, you would have had to pay the first 2 days of that hospital stay.
What a headache for physicians. I mean, like this is because it
Yeah,
puts you in an awkward spot, right? You don't want
right,
to have the patient have to pay for that, but at the same time, that's an inconvenience. I mean, you're in the middle of surgery,
right,
right?
right. And we have to do what's right for the patient, right? I'm never going to compromise patient care because an insurance company told me I couldn't do something. That doesn't fall on them. That falls on me. And our good friend Zane Hassan showed one of the like a little excerpt of one of the insurance company contracts with one of the providers he knew that said that they can't be held responsible for anything that happens, that the doctor still gets to make the choice. So, I mean, they've got this whole thing locked down where they can decide not to pay for care, but it's still on us to make sure that the patient gets the right care. And this brings us to Anthem, right? I don't know that we talked about this on the podcast.
Mhm.
Anthem in 3 states tried back when there were some issues with the CEO of United Healthcare. They tried back then to limit the length that they would pay for anesthesia, right? So they arbitrarily decided that procedures should take X or Y amount of time. And at the end of that time, if the procedure was still going, they would just stop paying the anesthesia provider. Yeah, what do you think's going to happen? I'm not going to shut the anesthesia off and tell the surgeon you can't keep operating. What's going to happen is I'm going to do the whole case, whether it takes an hour or 15 hours, and I'm just not
Mhm.
going to get paid for it, which was their whole plan. The plan was, how do we figure out a way to pay the anesthesia provider less? We know they're not going to just stop surgery after an hour, but we don't have to pay for it after an hour. So it's just the dirty tricks that the insurance companies do over and over and over again.
This is just really interesting because it opens up a whole can of worms, right? With what's happening in to our north, with
Yep.
our Canadian friends,
Yeah.
how they're feeling about care up there. Um, and it's just a different ball game. But I mean, what is, and we've talked about this before, what is the right answer, right?
Yeah.
What is the
So
fix?
so there's a few things that we could do. So I don't think that Medicare for all or socialized medicine is necessarily the answer. It probably works okay in Canada and it probably works okay in European countries, but we're sick, right? We're not a lot of the European countries, particularly the Scandinavian countries, are relatively healthy. And so it works as a system there, and probably even in Canada as well. Although you see that most people who want the best level of care and who want care quicker will just come to the United States and pay cash for their care, right? So the United States does have the best healthcare in the world. We have an insurance problem. And then if you listen to a lot of the public health people talk, we don't have a healthcare system. We have a sick care system, right? We don't incentivize having primary care, taking care of yourself, eating right, getting plenty of exercise, right? Getting out in the sun enough to get vitamin D, but not enough to get skin cancer, right? We don't prioritize those things. What our sick care system prioritizes is patient comes to the ER sick enough to be admitted, pays the doc and the hospital for that sick patient. So, I think what I've talked about over and over again is eliminating insurance companies and just doing direct to consumer, or direct to business, right? So we've got businesses in this area, big RV area, Lippert, right? Lippert's a huge RV company. They contract directly with several of the physician groups, private physician groups in the area for their care. There is no insurance company in the middle. Lippert, they say, okay, we're going to spend $1 million a year on health insurance or on health care. We're going to
We'll
cover
just pay
our
for it.
we'll just pay for it. And they can negotiate directly with an orthopedic group, a primary care group, a GI group, or whatever. And it takes out all that money that the insurance company is making because, let's say that the cost is, $1,000 for whatever, you know, 40% of that is going to the insurance companies, $400, right? So we can cut it down. We can say, okay, well, we're not going to charge, it's not going to cost you 1,000. We're going to charge, you know, 400, 300, and then the cost of service or whatever is another 300. We meet somewhere in the middle And then we say, okay, great. It's a $600 cost instead of 1,000 because we don't have to pay that $400 to the insurance company. And the premiums are lower, right? I mean,
Right.
they're probably not going to charge their own employees a ton in premiums. And the other thing you can do when you do that, you get rid of the insurance companies, is you can incentivize your employees to be healthy. You can say, if you smoke, I'm going to charge you an additional $500 a month. If you are over a certain BMI, I'm going to charge you extra per month. If you go to our exercise plan and you show, like I had this when I was an intern. If I had a certain number of steps per day, I got like, it was like 50 bucks, and I was a poor medical student or resident at the time. So I got $50 off a month on my health insurance plan if I did a
Yeah,
certain
a
number
certain
of
number of
steps a
steps a day,
day.
right?
Yeah, right. So I mean it's really easy for a local, like even just a straight employer in an area to incentivize the right types of behavior as opposed to United Healthcare, who, what do they care? The sicker you are, the more money they make. So,
That's a sad state in this world, right? In this
yep.
country. If that's what we're hoping, is the sicker we are, the better it is for them.
Yeah.
Interesting. We're gonna link the article below,
On Dr.
uh,
Potter, yeah.
on Dr. Potter.
Yeah.
Interesting conversation, though. I feel like we could talk in hours about this. But some of the other things that we have coming up, podcasts. You want to mention some of those other podcasts we have coming up?
Yeah, sure, absolutely. I think so. We're going to delve in pretty deeply to some things that have come up recently. One thing is there's a report out that a huge percentage, some say 40% of trainees who finish medical school and or residency decide not to go into clinical medicine. So they go into non-clinical aspects of medicine, either administration or pharmaceutical companies or something like that. I do particularly, and let's just talk about this today. There's one thing I really would like to talk about today because it's kind of forefront of mind in the state of Indiana. And I actually just found out that it didn't pass out of committee, but there was a proposed statute, a law that was in committee in the state of Indiana to allow pharmacists to diagnose and treat a certain number of conditions. And so, obviously the Indiana State Medical Association and all the Indiana physicians were very, very, very strongly opposed to this. Um, you know, I I don't think it's the role of a pharmacist to diagnose, prescribe, and treat, right? That's a physician or nurse practitioner or PA or whatever, right? That's not a pharmacist. Now, I love my pharmacist buddies, right? I call them all the time. Hey, this patient's taking, these 7 drugs. I want to give them something for pain. Which can I give them? I don't know, right? I don't know
Right.
all the contraindications and all that sort of stuff. So they're great. They're great, particularly in the hospital. They help us dose antibiotics. There's some antibiotics that have to be like not just weight based, but ideal body weight based dosing and all kinds of stuff. The pharmacists are awesome with that. They're great with a lot of things. But I think our argument as a physician community in the state of Indiana is they are not able to diagnose, prescribe, and treat. Particularly, I mean, I think they were talking about like flu and with this whole quademic thing. So I mean that we'll talk more about it later, but I at least wanted to introduce that as we moved into to
Who
some of the
backed that?
podcasts.
Who was like, oh, that's a good idea? Who came up with that?
I'm not sure. I mean, I think it came out of the health committee in the Senate, state Senate. And so I won't throw any names out there, but I know a fair amount of these people. So I can guess, but I don't know 100% who backed the
Yeah.
bill.
Well, we can. That's certainly interesting too. We could certainly talk
Yeah.
about that maybe next
Yeah, we'll
week.
talk. Yeah, we'll talk some more for sure. So I think the other things that are sort of at the forefront of mind, this whole thing where Trump cut back on the NIH indirect costs, and we'll talk about what those are and how those kind of fit into when you pitch a grant to the NIH. There's quite a bit of additional costs that go to the facilities, and so we'll talk about the changes there. Um, and then I would definitely, at some point, we're going to talk about the fact that ever since the ACA or Obamacare, physicians are not able to own hospitals. at least not large percentages, and they can't build their own hospitals either. So, and there's some were grandfathered in, but ever since 2010, that was something you couldn't do. So, and I think that's worthwhile to get into the history behind that and whether we think it's a good or bad thing. So,
Lots to come here on Going
yeah.
Under Anesthesia Answered, and hopefully you'll see us back together next week. So, this has been another episode of Going Under Anesthesia Answered, brought to you by Butterfly Network. For Dr. Brian Schmutzler, I'm Vahid Sadarzadeh. We'll see you in the next episode.